Appropriate Use of Temporary Central Lines by Christy Vandegrift for the University of Providence Capstone Project. Does eliminating inappropriate use of temporary central lines lead to decreased central line-associated bloodstream infections? Our hospital's high rate of central line utilization and central line-associated bloodstream infections, or CLABSIs, sparked the need for intervention. The lack of line selection and utilization policies and guidelines are contributing to a culture of complacency and inconsistent practice at our hospital. Using a change theory, we aim to improve the appropriate use of central lines by heightening awareness and providing patient caregivers with new tools and processes they can incorporate into their workflow. At this time, our trial unit is showing promising outcomes. During a collaborative infection prevention teams meeting for our hospital system, we were shown how all of the hospitals compared related to CLABSI data taken from NHSN for the previous 2 quarters. My hospital was at the top of the list with the highest central line utilization and the highest CLABSI rates. This sparked a great interest in finding out why, which led to this process improvement project. The first thing we needed to do was search the literature and find the current best practices so we will be able to identify our gaps. We narrowed down the literature search to temporary central lines, indications for central line insertion and continuation, central line duration, and timely central line removal. All of these have a part in central line utilization. The literature was not surprising. There are many widely publicized and accepted practice guidelines and recommendations from healthcare authorities such as the Institute for Healthcare Improvement, the CDC or Centers for Disease Control and Prevention, and even professional organizations like the Institute of Medicine. There are also regulatory agencies that weigh in on hospitals and preventing healthcare-associated infections, like the Centers for Medicare and Medicaid and the Joint Commission. The literature also reveals strong links between the inappropriate use of central lines and CLABSIs to mortality, litigation, and even negative patient satisfaction. Altogether, we found 12 practice guidelines and support articles. We found 10 cohort studies reporting compliance and observations and surveys about attitudes surrounding prevention measures. And we found 7 control cases that studied actual CLABSI cases and their possible causes. So what did the literature reveal? The practice guidelines, all the practice guidelines for CLABSI prevention included regularly assessing central lines for necessity and remove them when they're no longer essential. Most of the practice guidelines included selecting the appropriate line based on the treatment plan. However, only one, the MAGIC study, was the only one that specifically listed indications for selecting one type of line over another for specific treatments. I want to note here that our focus is on temporary central lines, so it does not include lines used for dialysis and chemotherapy. We found in the literature that lines, permanent lines were of interest, and so we did not use that literature. Of the studies and the observations, we found that the longer line duration increases utilization rates and increases the risk for acquiring a CLABSI due to prolonged exposure to the line and lack of focused care and maintenance like flushing and dressing changes. The patient caregivers frequently do not practice CLABSI prevention measures, especially assessing for appropriateness for insertion, including the physicians, or removal when the line is not essential anymore. For surveys and observation studies, we found findings around attitude, that the central line removal is not a priority. Caregivers know the guidelines, but they do not practice them 100%. Some are unsure about their organization's policies, and that having a central line is viewed as common practice. It's convenient, it's safe to always have a line just in case. Before diving into fixing the problem, it is important to choose the best change theory to help guide the improvement project. Change theories are proven and established. For this project, we chose Lippitt's 7-step change theory. We felt that this process was best as it provides a step-by-step approach for making progress. It requires collaboration with stakeholders, a project team representing all of the stakeholders, change agents, and a commitment to making the changes. Step 1, diagnosing the problem. The problem is higher than expected central line utilization and CLABSI rates, likely causing, in part, a high central line utilization rate. Step 2, assess the motivations and capacity to change. Improve patient safety. That is our motivation, is to improve patient safety by preventing CLABSIs, improve the quality of care that we deliver to our patients, and be in compliance with regulatory expectations. So then we covered Lippitt steps 1 and 2. Step 3, assess the resources and motivation and commitment. Our resources are available. Our change agents are our team members representing the stakeholders. Stakeholders are those that are impacted by the change and all have roles on the team. Senior leaders and administrators must have a presence on the team. They agree the problem exists and they express to all that the change is urgent. The leader must promote and support all of the team's efforts. We must have physicians on our team. Physicians must participate in the change. Many of the orders to insert and remove central lines are given by physicians, and they must know and agree to the changes. There must be an appointed team leader. In this case, our team leader is the infection prevention nurse. That nurse provides the data and the best practices, and she is the subject matter expert. Patient care staff from many areas must be on the team to effectively implement changes, strategies, provide input and feedback. The patient caretakers are essential in developing tools and strategies that will work and can be incorporated into their daily workflow. We included patient care nurses and vascular access nurses on our team. All team members participated in a brainstorming session to figure out why. This fishbone diagram is a pictorial categorization of our cumulative whys. Why was our utilization high? 4 categories emerged: policies, procedures, people, and environmental culture. It became clear that we are lacking in written policies, have no criteria guiding decisions, no ownership of processes or practices, nobody questioning the current practices, and basically just complacency. So then the question was, what can we do that will be most effective at changing the whys? In short, the team decided to create evidence-based policies for selecting intravenous lines, and removing them, develop a decision-making process and tool for assuring line appropriateness, and educating all the people impacted. The remaining area, environment, in this case environmental culture, should slowly change as the new expectations become everyday practice. Step 4. Select progressive change objective. Number 5, assures change agents clearly understand roles and responsibilities of change activities. And step 6, commit to and maintain change. First, our objective of the Process Improvement Project is for patient caregivers to follow established guidelines for CLABSI prevention and our change agents to develop a process for applying these best practices. Our goal is to prevent CLABSIs by decreasing the inappropriate utilization of central lines. Here is a current list of our team's accomplishments that will propel us towards meeting our objectives and our goal. Policy approval process was complete. The decision-making tool is in use, and it includes indications for central line insertion and continuation, considers anticipated duration, and it also considers the type of medications and infusions that will be given. The pilot continues on one of our med-surg floors. It has not been introduced to other units due to the focus and census fluctuation because of COVID-19. Our pilot started 4 months ago. The SUR utilization rate decreased by 18% compared to the previous 4 months, and there have been no CLABSIs compared to 1 CLABSI in the previous 4 months. Again, these results may be skewed a little due to COVID-19 impact. That impact is unknown. The auditing and checklist tool for assuring line necessity of removal is in use. It has gone through changes based on nursing feedback to improve ease of use. And we show a commitment to the changes due to several things. 1, we have a significant increase of awareness of the appropriate use of central lines. These people working on this med-surg unit and our physicians that are helping us with the change truly understand the reasons behind the guidelines and expectations. Plus, we have active physician participation and promotion for this central line indicators. Step number 7, gradually remove change agents. We are close to doing this for our pilot unit, and we feel very comfortable in doing that because in conclusion, knowing that we're eliminating inappropriate insertion of temporary central lines, we're going to have a greater benefit. Some of those benefits include promoting patient safety by preventing other CLABSIs and possibly decreasing mortality, improving patient satisfaction, realizing significant cost savings that may be related to supplies and non-compensation for CLABSIs, compliance with regulatory agency and their standards, and possibly avoiding litigation. I want to thank you for joining me as I summarize my project for assuring appropriate use of temporary central lines at my hospital.